Good evening, everybody, and thank you very much for joining this Zoom session for this webinar on this very important day. A warm welcome to all of you. On this slide, you will see the next two webinars that we have lined up, that is on the September 17th and September 24th. So please keep the date and time free to Zoom in. They are very interesting webinars like today's one. We have also got 4 competitions lined up. The first 2 are creative writing and the art competition. Details are in these slides. And then there's a digital art competition as well as a photography competition. Please note the closing dates for submission of entries. World Suicide Prevention Day is an awareness day observed on 10th September every year since 2003 to provide worldwide commitment and action to prevent suicides. The IASP collaborates with the WHO and the World Federation for Mental Health to spread awareness around the world. The theme this year is creating hope through action, which encourages all of us to consider the role that offering support may play in combating suicide. We are all part of a community linked to family, friends, work, colleagues, neighbors, or teams. Sometimes we become isolated and disconnected from our communities. Social connectedness reduces the risk of suicide. So being there for someone who has become disconnected can be a life-saving act. We have the responsibility to support and empower those who become vulnerable in our communities. If you're worried about someone in your community, reach out and ask them, are you okay? By simply checking in with them and offering non-judgmental support, you can make a big difference. It is important to know that people in distress are often not looking for specific advice, but merely to be listened to with compassion and empathy. We warmly welcome all those present today who have accepted our invitation and have joined us to remember those who have chosen to end their lives having found living unbearably painful. We will also remember those survivors whose lives have been shaken by suicide of a loved one, and hope that they will be able to gather strength and support to cope and walk ahead in their lives. Sumithrayo has been around since 1974 to support and empower anybody going through a crisis in their lives. We also kindly request that you join us in lighting a candle wherever you are with individuals from all over the world in support of World Suicide Prevention Day at 8 p.m. this evening to remember lost loved one and the survivors of suicide. I now call upon Kanchana to read the welcome address in Sinhala. Thank you.
Thank you, Jomo. සුබ සන්ධ්‍යාවක් සියලු දෙනාටම සැප්තැම්බර් 10 වෙනි දිනට එදී තිබෙන ලෝක සියදිවි හානි කර ගැනීම වැළැක්වීමේ දිනය 2003 වර්ෂයේ සිට සැමරීම සිදු කරන්නේ විශේෂයෙන්ම ඒ පිළිබඳ දැනුවත් කිරීමේ දිනයක් ලෙස. ලෝක සෞඛ්‍ය සංවිධානයත් මානසික සෞඛ්‍ය පිළිබඳ ලෝක සංවිධානයත් සම්බන්ධ කර ගනිමින් ජාත්‍යන්තර සියදිවි හානි කර ගැනීම වැළැක්වීමේ සංවිධානය සියදිවි හානි කර ගැනීම වැළැක්වීම සම්බන්ධයෙන් දැනුවත් කිරීම ලොව පුරා සිදු කරන ලබනවා. මෙම වර්ෂයේ තේමාව වන්නේ ක්‍රියාව තුළින් බලාපොරොත්තු ඇති කිරීම. මෙම තේමාව හරහා දිරිගැන්වීම සිදු කරනු ලබන්නේ පවුල් ඒකක, මිත්‍රයින්, රැකියා ස්ථානයේ සගයන්, අසල්වාසීන් යන විවිධ ආකාරයෙන් එකම සමාජයේ කොටස්කරුවන් වන අප අන් අයට උදව් කිරීමට ඉදිරිපත් වීම මගින් දිවි හානි කර ගැනීම වළක්වා ගත හැකි බවට ප්‍රචලිත කිරීමට. සියදිවි හානි කර ගැනීමේ අවදානම අඩු කරන සාධකයක් වන්නේ සමාජ බැඳීම. ඇතැම් අවස්ථාවලදී පුද්ගලයන් හුදකලා වී සමාජයෙන් වෙන් වී සිටින අවස්ථා අපට දක්නට ලැබෙනවා. එවන් අවස්ථාවලදී එලෙස හුදකලා වී සමාජ සම්බන්ධතාවයෙන් වෙන් වී සිටින පුද්ගලයන් වෙනුවෙන් කාලය යොමු කිරීම හා ඔවුන්ට උපකාර කිරීමට ඉදිරිපත් වීම ඔවුන්ගේ ජීවිතය ආරක්ෂා කිරීමට පවා හේතු වනු ඇත. එලෙස අවදානමට ලක් වී ඇති පුද්ගලයන් කෙරෙහි අවධානය යොමු කිරීම ඔවුන්ට උපකාර කිරීමත් නිවැරදි තීරණ ගැනීම උදෙසා ඔවුන් දිරිගැන්වීමත් අප සැමගේ වගකීමක් වෙනවා. ඔබ අවට සිටින කිසිවෙකු හෝ පිළිබඳව ඔබ කනස්සල්ලෙන් සිටිනම් ඔවුන්ට ඔබගේ අවධානය යොමු කරලා ඔවුන්ගෙන් ඔබ හොඳින්ද කියා අසන්න. එම සරල ප්‍රශ්නය ඇසීමෙන් සහ ඔවුන් ගැන කිසිදු විනිශ්චයකින් තොරව උපකාර කිරීමට ඉදිරිපත් වීම මගින් ඔවුන්ගේ ජීවිතය තුළ විශාල වෙනසක් සිදු කිරීමට ඔබට හැකියි. අප විශේෂයෙන්ම තේරුම් ගත යුතු දේ වන්නේ පීඩාවට පත් වී සිටින පුද්ගලයෙකු සෑම විටම අවවාද බලාපොරොත්තු නොවන බවයි. ඔවුන් විශේෂයෙන්ම බලාපොරොත්තු වන්නේ සානුකම්පිතව සහ සහකම්පනයෙන් යුතුව ඇහුම්කන් දීමක් බවත්ය. ජීවත් වීම ඉතා වේදනාකාරී බව සිතා සිය ජීවිතයෙන් සමුගත් සියලු දෙනා සිහි කිරීමට අද දිනේ අපගේ ආරාධනය පිළිගෙන අප හා සම්බන්ධ වී සිටින ඔබ සියලු දෙනා මේ අවස්ථාවේදී අපි ඉතා ආදරෙන් පිළිගන්නවා. තවද දිවි හානි කර ගැනීමට උත්සාහ කර එයින් මිදුන අයටද තම ආදරණීයෙකුගේ දිවි හානි කර ගැනීමක් නිසා තදබල ලෙස කම්පනයට පත් වූ සියලු දෙනාද මේ අවස්ථාවේදී අපි ඉතා ආදරෙන් මතක් කර සිටින අතර ඔවුන්ට ජීවිතයේ ඉදිරියට යාමට අවශ්‍ය ශක්තිය හා උපකාරය ලැබේවායිද ප්‍රාර්ථනා කර සිටිනවා. 1974 වර්ෂයේ සිට මේ දක්වා පීඩාකාරී අවස්ථාවලට මුහුණ දෙන ඕනෑම කෙනෙකුට චිත්ත වේගී යහ පැවැත්ම පවත්වාගෙන යාමට නිවැරදි තීරණ ගැනීම සඳහා දිරිගැන්වීමට සේවය සැපයීම සුමිත්‍රා ආයතනය මගින් සිදු කෙරෙනවා. ලෝක සියදිවි හානි කර ගැනීම වැළැක්වීමේ දිනය සනිටුහන් කරමින් අද රාත්‍රී 8ට ඔබ සිටින ස්ථානයේ සිටම ලෝපුරා සිටින සියලු දෙනා සමග එක්ව සියදිවි හානි කරගත් සහ එයින් දිවි බේරාගත් ආදරණීයයන් සිහිපත් කරමින් අප හා එක්ව පහනක් දල්වන මෙන් අප ඉතා කරුණාවෙන් ඉල්ලා සිටිනවා. And now I would like to call upon Nandani to deliver the speech in Tamil.
Thank you, Kanchana. இணையதளம் மூலம் இணைந்திருக்கும் அனைவருக்கும் வணக்கம். உலக தற்கொலை தடுப்பு தினம் என்பது 2003ஆம் ஆண்டு முதல் ஒவ்வொரு ஆண்டும் செப்டம்பர் மாதம் 10ஆம் திகதி விழிப்புணர்வு தினமாக அனுசரிக்கப்படுகிறது. இது உலகளாவிய அர்ப்பணிப்பு மற்றும் தற்கொலைகளை தடுக்க நடவடிக்கை எடுக்கிறது. உலகெங்கிலும் விழிப்புணர்வை பரப்புவதற்கு வலி ஆய்வுக்கான சர்வதேச சங்கம் உலக சுகாதார சங்க அமைப்புடன் ஒருங்கிணைந்து மற்றும் மனநலத்திற்கான உலக கூட்டமைப்பும் ஆகியவற்றுடன் ஒத்துழைக்கிறது. இந்த ஆண்டு கருப்பொருள் செயல் மூலம் நம்பிக்கையை உருவாக்குதல். இது தற்கொலையை எதிர்த்து போராடுவதில் ஆதரவை வழங்குவதற்கான பங்கை கருத்தில் கொள்ள நம் அனைவரையும் ஊக்குவிக்கிறது. நாங்கள் அனைவரும் ஒரு சமூகத்தின் ஒரு பகுதியாக இருந்து குடும்பம், நண்பர்கள், பணிபுரியும் சக ஊழியர்கள், அண்டை வீட்டார்கள் அல்லது குழுக்களுடன் இணைக்கப்பட்டுள்ளோம். சில சமயங்களில் நாம் தனிமைப்படுத்தப்பட்டு நமது சமூகங்களில் இருந்து துண்டிக்கப்படுகிறோம். சமூக தொடர்பு தற்கொலை ஆபத்தை குறைக்கிறது. எனவே துண்டிக்கப்பட்ட ஒருவருடன் இருப்பது ஒரு உயிரை காப்பாற்றும் செயலாகும். எங்கள் சமூகங்களில் பாதிக்கப்படக்கூடியவர்களுக்கு ஆதரவளித்து அதிகாரம் அளிக்கும் பொறுப்பு எங்களுக்கு உள்ளது. உங்கள் சமூகத்தில் உள்ள ஒருவரை பற்றி நீங்கள் கவலைப்பட்டால் நீங்கள் நலமாக இருக்கிறீர்களா என்று அவர்களிடம் கேளுங்கள். அவர்களின் நலத்தை விசாரித்து பாராபட்சமின்றி ஆதரவை வழங்குவதன் மூலம் நீங்கள் மாற்றத்தை ஏற்படுத்தலாம். துன்பத்தில் உள்ளவர்கள் பெரும்பாலும் குறிப்பிட்ட அறிவுரைகளை தேடுவதில்லை. மாறாக இரக்கத்துடன், அனுதாபத்துடன், முனைப்புடன் செவிமடுக்க வேண்டும் என்பதை அறிவது முக்கியம். எங்களின் அழைப்பை ஏற்று தாங்க முடியாத வேதனையுடன் வாழ்க்கையை முடித்துக் கொள்ள தேர்ந்தெடுத்தவர்களை நினைவு கூற எங்களுடன் இணைந்திருக்கும் அனைவருக்கும் இன்று அன்புடன் வரவேற்கின்றோம். நாம் நேசிப்பவரின் தற்கொலையை இன்னும் உயிருடன் இருப்பவர்களை நினைவு கூர்வோம். மேலும் அவர்கள் தாங்கள் வாழ்க்கையை சமாளிப்பதற்கும் முன்னேறுவதற்கும் வலிமையையும் ஆதரவையும் சேகரிக்க முடியும் என்று நம்புகிறோம். சுமித்ரயோ 1974ஆம் ஆண்டு அவர்களின் வாழ்க்கையில் நெருக்கடிகளை சந்திக்கும் எவருக்கும் ஆதரவளித்து அதிகாரம் அளிப்பதற்காக செயல்பட்டு வருகிறார்கள். உலக தற்கொலை தடுப்பு தினத்திற்கு ஆதரவாக இன்று இரவு 8 மணிக்கு தற்கொலையால் இறைவனாடி எய்தியோரையும் தற்கொலை முயற்சியில் ஈடுபட்டு உயிர் பிழைத்தவர்களையும் நிறைவு கூறும் வகையில் உலகம் முழுவதிலும் இருக்கும் தனிநபர்களுடன் நீங்களும் எங்கிருந்தாலும் மெழுகுவர்த்தி ஏற்றி எங்களுடன் சேருமாறு அன்புடன் கேட்டுக்கொள்கிறோம். நன்றி. Yes, Jomo, you can.
Thank you, Nandini.
Continue.
I would like to give all of you a brief introduction to the panelists. Dr. Rohan Ratnayaka is the Directorate of Mental Health consultant community physician. Dr. M. Ganeshan, senior consultant psychiatrist at the NIMH. Dr. Neil Fernando, senior consultant psychiatrist and senior lecturer at Kotalawala Defense University. I now call upon Dr. Rohan Ratnayaka to make the keynote speech.
Good evening, everyone. The chairperson, directors, and staff of Sumithrayo, and resource persons, and all those who are present here today. So I have a great pleasure working with Sumithrayo, which is doing a great service to the people in this country. Dear ladies and gentlemen, there is an alternative to most of our grievances. This is true in suicides too. Simple actions can give hope to those who are struggling. We all can play a vital role in saving lives. We can make a difference to someone in their difficult moments, may it someone experiencing suicidal crisis or bereaved by suicides. There is no one fit for all strategy, and it has to be individualized. Someone having suicidal thoughts may feel that they are a burden to their loved ones and feel alone. Recent developments in the country have contributed to and aggravated this feeling of isolation. We need to create an environment that they hope that there are people who care and want to support them. This is not, the helping is not strange to us. We always devalue our significance and think that only professionals can help, but it is not true. Reach in and listen to their experiences of distress and suicidal thought. Create a sense of connection and hope. Personal stories of someone's experiences of emotional distress, suicidal thoughts or suicidal attempts, and recovery if any, and their inner world can help us understand feeling suicidal and how we can help others. Sharing experiences of overcoming of being bereaved, have inspiring and hope in those having the same experiences. It is not fair to have one dedicated day to talk about losing our precious lives. Every moment when someone needs our help is Suicidal Prevention Day. However, this is not the practical scenario. So we can create an opportunity to raise awareness of suicide and sensitize the policymakers of the gravity of the problem on this particular day. The theme in every year may be different, but the message or the action is the same. That is to reach out to those who need help. Ask directly if they are thinking about suicide. Listen to them and keep them safe. Let them know that we have something for them. Suggest if we think there's a need of a mental health professional, suggest to them. And ladies and gentlemen, no one is immune to having suicidal thought. It doesn't care for the race, religion, creed, or any social status. Let them seek immediate help from a trusted friend or family member or healthcare provider. If they have suicidal thoughts, Ask them to seek professional help. Ask them not to act on their thoughts right now, and try to focus on just getting through today. You might have had this sort of thoughts earlier too, but you are able to cope up in a few days. And keep them safe and encourage them to talk to people. Being around and encourage them to being around people, even if they don't want to talk to. Try doing things that they are enjoying. By raising awareness and encouraging culturally appropriate actions, we can reduce suicides. Sri Lanka experienced 3,200 odd suicides in 2021. World Suicide Prevention Day is an opportunity to raise awareness of suicides and to promote action through practical ways. This will reduce the number of suicides and suicide attempts. Everyone you meet is fighting a battle you know nothing about. Be kind always. Mental health is a right of the people. සුබ සන්ධ්‍යාවක් වේවා. අපි මේ ජීවිතවල වටිනාකම ගැන කතා කරන්න එක දවසක් වෙන් කිරීම මම හිතන්නේ සාධාරණ නැහැ කියලා මට හිතෙනවා. යම් කෙනෙකුට අපේ උදව්ව අවශ්‍ය වන හැම මොහොතක්ම මම හිතන්නේ සියදිවි හානි කර ගැනීම වැළැක්වීමේ දවසක් කියන එකයි මගේ අදහස වෙන්නේ. ඒක තමයි මම හිතන්නේ කාගෙත් අදහස. ඉතින් අද දිනේ අරමුණු තමයි අපි හැමදෙනාටම අනිත් අයගේ ජීවිත ආරක්ෂා කරගන්නයි, ඒ වගේ මේ ජීවිත ලස්සන කරගන්නත් අවස්ථා තියෙන බව කියලා දෙන එක. අපිට ඕන තරම් අවස්ථා තියෙනවා අනිත් අයගේ ජීවිත ලස්සන කරන්න. ඒ වගේම මෙම මේ ප්‍රශ්නේ කියන්නේ මේ සියදිවි හානි කර ගැනීමේ ප්‍රශ්නේ තියෙන බරපතලකම ගැන කියා දෙන එක අද දවසේ අපිට තියෙන එක වගකීමක්. ඒ වගේම මේක එක ඔබ්ජෙක්ටිව් එකක්. හැම අවසරකම සියදිවි නසා ගැනීම බලක්වයා ගැනීමේ දිනේ තේමාවල් වෙනස් වුණාට දෙන පණිවිඩය එකයි. එනම් ජීවිතය ගෙන යන්න අවශ්‍ය උදව් ඕන අයට උදව් කරන එක. ඕක තමයි ඇත්තටම හැම අවුරුද්දෙම අපිට දෙන්න ඕන පණිවිඩය. ඕනෑම කෙනෙකුට ජීවිතය නැති කරගන්න ගැනීමේ සිතුවිලි ඕනම වෙලාවක පහළ වෙන්න පුළුවන්. ඒකට අපේ තරාතිරම ආගම ජාතියේ අදාළ නැහැ. ඉතින් ඔවුන්ට සවන් දෙන්න, ඔවුන් ආරක්ෂිතදයි බලන්න, ඔවුන් වෙනුවෙන් අපට කළ හැකි යමක් කළ හැකි බව ඔවුන්ට ඒත්තු ගන්නන්න. අපි හිතනවා නම් මානසික සෞඛ්‍ය හා සම්බන්ධ වෘත්තිකයෙකුගේ උදව් අවශ්‍යයි කියලා. ඒක එයාලට යෝජනා කරන්න. කා සමග හරි එයාලට කතා කරන්න දිරිගන්වන්න. සමහර වෙලාවට එයාලට කතා කරන්න අවශ්‍ය වෙන්නේ නැති වෙයි. එහෙම වුණොත් කට්ටිය සෙනග ඉන්න යවසන අනිත් ඉන්න තැනක එයාලට කාලය ගත කරන්න දිරිගන්වන්න. අද දවස ගත කරන එක ගැන පමණක් ඒගොල්ලන්ගේ හිත යොමු කරවන්න. මීට පෙර ඒගොල්ලන් මේ වගේ සිතුවිලි තියෙන්නේ නැති, ඒවා සාර්ථකව ජය ගන්නත් ඇති. එහෙම තියනා නම් ඒවා ගැන කියලා දෙන්න. ජීවිතයේ යථා තත්ත්වයට දින කිහිපයකින් ආයේ පත් වෙනවයි කියන එකත් එයාලට කියලා දෙන්න. ඉතින් සෞඛ්‍ය අමාත්‍යාංශය පැත්තෙන් ගත්තම අපි ගොඩාක් ක්‍රියාමාර්ග අරගෙන තියෙනවා. මේ ක්‍රියාමාර්ග අපි ගොඩාක් අරගෙන තියෙනවා සියදිවි හානි කර ගැනීම වළක්වීමට. මම හැමෝටම ආරාධනය කරනවා අපි සේරම අය මේ සමාජ සත්කාරය මේ social responsibility එකට අපි දායක වෙන්න කියලා අපි සේරම එක්කහුවෙමු කියන එක. මම හිතන්නේ මේ අපි කවුරුත් දන්නවා මානසික සෞඛ්‍යයක් නැති තැන සෞඛ්‍යයක් නැහැ. There is no health without mental health. ඉතින් අද දින මෙම වැඩසටහන මේ සංවිධාන මේ සුමිත්‍රයෝ ආයතනයේ විසින් සංවිධානය කරපු මේ වැඩසටහන එම ආයතනයේ ගොඩාක් මහන්සි වෙලා තියෙනවා මේක සංවිධානය කරන්න. ඉතින් අපි මම පෞද්ගලිකවත් නමුත් සෞඛ්‍ය අමාත්‍යාංශයේ නියෝජනය කරන කෙනෙක් විදිහට මම එම ආයතනයේ සභාපති ඇතුළු එම අධ්‍යක්ෂ මණ්ඩලයයි කාර්ය මණ්ඩලයටයි ගොඩාක් ස්තුතිවන්ත වෙනවා. මේ වගේ වැඩසටහන් අපි රාජ්‍ය නොවන සංවිධාන විසින් මේවා අතට අරගෙන පවත්වන එක ගැන ස්තුතියි.
Thank you very much, Dr. Ratnayaka, for that very interesting keynote address, which gave us an overview of suicide in Sri Lanka. Thank you so much for finding the time. Would like to get on with asking the panelists some questions, interesting questions. And I request all of you who have zoomed in to use the Q&A at the bottom of your screen to ask any questions that you feel that you need to know more about. And the panelists will be very happy to answer them at the end of the session. So moving on to the first question to the panelists. Dear doctors, in Sri Lanka, behaviors that lead to self-harm often arise impulsively, with little or no warning or no history of depression. A family quarrel or sudden disappointment might cause feelings of rejection, frustration, and anger, leading to an attempt. Such thoughts can develop in a matter of hours or even minutes, leaving very little time for family or friends to see the danger signs and intervene. People going through this sudden distress don't have time to reflect on their thoughts or try to speak to someone. This can pose real challenges for suicide prevention in Sri Lanka. Dr. Neil Fernando, how can stakeholders and gatekeepers help people to acquire life skills to help them navigate and survive such moments of impulsiveness? Should we consider including this as a compulsory subject in the school curriculum?
Okay, thank you for inviting me for this interesting discussion. And I would also like to echo the same words stated earlier by our Director Mental Health, that Sumithrayo has always taken a leading role when it comes to suicide prevention. So thank you very much for organizing, not only here, but every year on this very interesting and very important subject, suicide prevention. Now, your question, to answer that question, I look at the suicide as a process. It is a process. And this process, for our convenience or for our easy understanding, which is a very, very complicated process, but it is easy to understand this process as having 3 stages. Namely, the first stage would be the suicidal intent. I will name it as the intention stage. Following the intention, you go into the second stage, that is the suicidal act. That is the physical act that follows the intention. And thirdly, you get the third phase, which is the outcome of that action or the act. And the outcome can be either the person has died, then it becomes suicide, labeled as suicide, or the person can survive. which is then called, of course, there is no one universal word for this. People call it suicidal attempt or attempted suicide, or some people even call it parasuicide. But anyway, that is the third stage. So in the third stage, you have two groups actually. One who have actually died as a result of the act, which is called suicide, and the other group which has survived the act. Right. So this is the process that goes on. Now, each one will travel in this process at different speeds. Now, you mentioned about this impulsive acts. Impulsive act, by definition, is impulsive act is an act a person engages in without thinking about the consequences. I mean, that is the common understanding about an impulsive act. So, you can have impulsive acts in relation to suicidal behavior as well. Now, in an impulsive act, what happens is that this process of starting from the intention, then the suicidal act, and the outcome is actually a sort of fast forwarded, right? It goes very fast. And as a result of that, a person will travel through these stages very, very fast. Now, that is at one extreme. As opposed to that, you have the other extreme where this process can be very, very slow or prolonged. So that the person may live with a suicidal intention, gradually increasing momentum, but over a period of time, and then may indulge in an act, or that may also be sometimes prolonged. The person may start the act and then may stop it, and again might start it like that. So the act itself can be also prolonged, and of course the outcome. The outcome is the same, either the person has died or the person has survived. So this is how I look at this process. So in Sri Lanka, we find people engaging in these two ways. One is the impulsive way, which you mentioned. Other one is a slow process going on a slow way. Now, when it comes to prevention, it is easy to prevent the second group rather than the first group, because the first group who act impulsively in a very short period, the chances of preventing it might be sometimes even almost impossible. But there is also a difference. Now, that's why I said this is complicated. Now, if you look at the people who end up in this process, that is those who have died and those who have survived. When you look at these two groups, there are certain differences in the two groups also. In the group who dies, that is the people who commit suicide, there are more males. And this is a worldwide phenomenon, right? I think if I remember correctly, for every 4 suicides, 3 are males. So males outnumber females in the first group, that is the people who die. Whereas in the second group, you have more females, right? More females. But again, when it comes to Sri Lanka, again, things are complicated. If you look at the Sri Lankan situation, this male to female ratio is also reducing. In other words, the stated difference, that is 3 to 1 suicide, is is also changing in Sri Lanka. So that's why I said these are very complicated issues. But this is how I look at it. So one other point before I finish, this to be called act as suicide, I think the intention becomes very, very important. Intention to die. Intention to die. And if you look at the WHO definition, suicide has 3 parts, and all 3 have to be there for it to be named as suicide. First is it's a process that ends with death. So there should be a death at the end of the process. Then the process has to be started and conducted by the person himself or herself. That is the intention part. And also the third one is that the person should know that the person is going to die as a result of this act, and actually that is the wish of the person. So this is the exact definition of suicide. But as we know, any impulsive act resulting in death is now labeled as suicide. So that is why now there is another process called a psychological autopsy. This is a psychological mechanism to really find out what was the real intention of this particular person, whether it was really to die or whether it is something else that led to this behavior. Now, that second group is where the intention is not to die. Now, the intention may be to seek attention, maybe to manipulate another person, or maybe just a reaction to an ongoing stress. Whatever the intention, the intention is not to die. So that is something that we need to bear in mind. So I think I will stop there. Do you want me to discuss this also, summarize it in Sinhala, or someone else?
Yeah, if you can quickly do that, Doc.
Right, okay. Not taking much time. Then
Yes,
mama me
please.
පැහැදිලි කරේ මේ අහපු ප්‍රශ්නය මේ සියදිවි නසා ගැනීම මේ ක්‍රියා මම දකින්න මේක ක්‍රියාවලියක් විදිහට ඒ ක්‍රියාවලියේ අධියර 3ක් තියෙනවා. මේක අපේ පහසුව සඳහා අපි හදාගෙන තියෙන්නේ. තේරුම් ගන්න පහසුවට ඒ අධියරේ පළවෙනි අධියර තමයි චේතනාව. සියදිවි නසා ගැනීමේ චේතනාව. ඒ චේතනාව ඊට එහාට ගිහිල්ලා ක්‍රියාවකට පෙරලෙනවා. එතෙන්දි තමයි සියදිවි නසා ගැනීම ක්‍රියාවක් සිද්ධ වෙන්නේ. ඒක භෞතික ක්‍රියාවක්. ඒ ක්‍රියාවේ ප්‍රතිඵලයක් හැටියට එනවා තුන්වෙනි අධියර. ඒකේ ප්‍රතිඵලය එක්කෝ මිය යන්න පුළුවන්. මිය ගියොත් අපි කියනවා සියදිවි නහගත්තා කියලා. මිය ගියේ නැත්නම් අපි කියනවා සියදිවි නහ ගන්න උත්සාහ කරා කියලා. ඉතින් මේක අපි සරලව මෙහෙම කිව්වට මේක ටිකක් සංකීර්ණ ක්‍රියාවලියක්. ඒකට හොඳ උදාහරණයක් තමයි අර අවසානයේ ලැබෙන ප්‍රතිඵලය දිහා බැලුවොත් අපිට පේනවා වෙනස්කම්. සියදිවි නහගත්ත ගොඩේ වැඩිපුර ඉන්නේ පිරිමි පාර්ශ්වය. සියදිවි නහගන්න උත්සාහ ගත්ත ගොඩේ වැඩිපුර ඉන්නේ කාන්තා පාර්ශ්වය. මේක ලෝකයේ සාමාන්‍යයෙන් හැමතැනම තියෙන ප්‍රවණතාවය. ඉතින් ඒකෙන් පේනවා මේ හැමෝම මේ සියදිවි නසා ගැනීමේ ක්‍රියාවේ යෙදෙන හැමෝම සමාන නෑ කියන එකයි. ඒකේ වෙනස්කම් තියෙනවා. ඒ වගේම ලංකාව මේක තවත් සංකීර්ණ වෙනවා. ලංකාවේ අපිට පේනවා මේ දෙගොල්ල අතර තියෙන මේ වෙනස, මේ ස්ත්‍රී පුරුෂ වෙනස, ඒ අනුපාතයත් අඩු වෙගෙන යන බව අපිට පේනවා. ඒක එකක්. ඒ වගේම අපේ රටේ සියදිවි නසා ගන්න ප්‍රමාණය දැන් රොහාන් කිව්වා 3000 ගණක් කියලා ගිය අවුරුද්දේ. ඔව් 95 දී මේක 9000 ගණක් තිබුණා. දැන් 9000 ඉඳලා 3000ට අඩු වෙලා තියෙනවා. ඒක හොඳයි. හැබැයි අපි මතක තියාගන්න ඕන සියදිවි නහගන්න උත්සාහ ගන්න අයගේ ප්‍රමාණය අඩු වෙලා නැහැ. ඇත්තෙන්ම එන්න වැඩි වෙන බවක් තමයි සංඛ්‍යාලේඛන අනුව පේන්නේ. ඉතින් මේ ක්‍රියාවලිය මේකේ මේ ඉන්ටෙන්ෂන් එක නැත්නම් චේතනාව ගත්තොත් ඒ චේතනාව සියදිවි නසා ගැනීම සඳහාම වෙන්නත් පුළුවන්. එහෙම නැත්නම් වෙනත් චේතනාවක් ඇතිව මෙවැනි ක්‍රියාවක නියැලෙනවා වෙන්නත් පුළුවන්. ඒ වෙනත් චේතනාවක් කිව්වේ සමහර විට අවධානය ලබා ගැනීම සඳහා යොදා ගන්න මාර්ගයක් වෙන්න පුළුවන්. තව කෙනෙක්ව අන්න අයව හසුරවන්න මේක යොදා ගන්න ක්‍රමවේදයක් වෙන්න පුළුවන්. එහෙම නැත්නම් තමන් මුහුණ දෙන මානසික පීඩාවකට අපි කියන ස්ට්‍රෙස් එකකට දක්වන ප්‍රතික්‍රියාවක් හැටියට වැනි හැසිරීම් වල යෙදෙන්නත් පුළුවන්. ඉතින් ඒ නිසා මේ ක්‍රියාවලිය අපිට පිටින් පේනුනට ඒක එක වගේ කියලා ඇතුලෙන් බැලුවම අපිට පේනවා ටිකක් සංකීර්ණයි කියන එක.
Thank you very much, Dr. Neil, for that very, very detailed response and explanation, which I'm sure all the viewers would have appreciated. I'll move on to the next question. Self-harming can be caused by economic, social, and political turbulence, or a culturally embedded response to interpersonal disputes. For example, arguments between spouses, parents, and children, and some extended kin. Failed love affairs, extramarital affairs, and failed examinations and job opportunities are also frequently cited. In many cases, shame is recognized as a leading cause. Self-harm to end one's life may be attempted to escape shame or to cause shame to another person, and even to extract revenge. In many cases, these attempts may be a means of communicating one's psychological and emotional needs. Dr. Ganesan, can you give us your thoughts on all of this? How can information on other options available be disseminated to the community?
Thank you very much, Jomo, for asking me that question. And thank you first for Sumithrayo for inviting me, because suicide is a big issue in Sri Lanka. So what you asked is very important, like why do we commit suicide or attempt suicide? It's a very important question because sometimes when we see the reasons look very trivial and very nonsensical, and that's kind of we don't pay enough attention, importance to that. So one of the problem is that when we are very emotional, aroused, whatever the emotion, right? I mean, usually when it's suicide, it's the negative emotions. What happens is our thinking processes are cut off. That our frontal lobe, which is very important for logical, rational thinking, is not actually working. And that's what Dr. Fernando and you said as impulsive acts. So very often when we become emotional, we act, do various things, either violence against others or sometimes violence against yourself, which we feel ashamed after when we analyze it. So that is one important aspect. Teaching our youth, teaching our people not to do anything when we are highly emotional. When I'm very happy, I tend to spend money unnecessarily. When I'm very unhappy, either I'm nasty to other people or nasty to myself. When I'm very sad, I'm thinking of suicide or hurting myself. So when we are in a highly aroused emotional state, not to take any decisions or not to do any activities. This highly aroused emotional state is not going to last very long. It's going to last maybe 5-10 minutes max. Right? So at that moment, when we are highly aroused emotionally, suicide may appear as the only solution. So very important thing is knowing that I'm highly emotionally aroused, anger, sadness, frustration, whatever, and I'm not going to do anything now. I'm going to wait 10-15 minutes until my emotion settles, and then let us see what's the best way forward. So that is something that we can teach our children, and that can be, like you asked in the first question, can be included in the school curricula to teach people to identify these highly aroused emotional states. We have all been there. For whatever reasons, we get highly angry, highly sad, etc. So that is very important. And also this concept of shame. Where do we learn it? Are we born with it? No, we are not. Right? So it's the society that teaches shame. Right? Comparing with other children, undervaluing our children. See, you are not good as other child. See, the other child is getting better marks. The other child is an obedient child. See how proud their parents will be. Unfortunately, these are common things that children hear in Sri Lankan homes. And that inculcates a sense of shame, a sense of failure, and then any threat on shame, on their self-being, is seen as a major problem. So teaching our children that, of course, we will make mistakes. We are not going to be successful in a lot of things. And creating a sense of self-worth in us. Hey, you are valuable for us, whatever marks you get. We are valuable for us, you don't excel in sports or something. So unfortunately, that's not the message children are hearing in their homes. Children are hearing in the schools as well, right? So shaming children and making them sensitive to shame is not a very good idea. But unfortunately, that seems to be a trend, and shame has become such a kind of a huge elephant in the room, or whatever you would call it, right? That kind of drives a lot of our behaviors, which bring us lots of unhappiness. And as you said, even suicides and suicide attempts. Yes.
Thank you, Doctor. Thank you so much. That was a great reply and a great response. I'm sure everybody would have appreciated it, especially your thoughts on shame. I feel that that's very, very important for everybody to consider. And your comment that shame, we are not born with shame, but we acquire it through social engagements and probably missiles from society. Thank you so much. On to my third question. The Sri Lankan Health Service has reduced the maternal mortality rates to 30 per 100,000 in 2020, which is great. In contrast, the rates of maternal suicide have shown an upward trend from 0.8 per 100,000 live births in 2002 to a rate of 12.1 per 100,000 live births in 2010. This data after 2010 does not seem to be available, so I can only bring forward the 2010 data, which is quite alarming. The effect of suicide during pregnancy or during the intermediate postpartum period is far-reaching. Apart from the calamity of the loss of life of a mother, it impacts on living children, family, and community. Early identification, referral, and management of high-risk mothers is likely to help reduce this tragic outcome. Dr. Ratnayaka, can we have your views on this situation, which is hardly brought up in forums about suicide?
Yes. Yes. What you said is true. The one reason for this is the maternal death rates are in par with the most developed countries. So we have reduced maternal deaths to a great extent. Right?
Yes.
අහපු ඔය ප්‍රශ්නේ හරි ඒක කොහොම තමයි ඒක හේතුවක් තමයි දැනට දැන් මව් මරණ කියන එක අපේ රටේ හොඳටම අඩුයි. අපි ඒ පැත්තෙන් ගත්තම අපි මේ අර දියුණු වෙච්ච රටවල් එක්ක හා සමානව තමයි මේ මව් මරණ පිළිබඳ දත් අපිට තියෙන්නේ. එතකොට දැන් මව් මරණ අඩුවෙද්දී ඒ කියන්නේ අපේ health services මේ improve the services මිනිස්සු ළඟට ළඟා වෙද්දී emergency care improve මව් මරණ ඒ වගේ අඩු වෙනවා වගේම දැන් මේ ප්‍රතිශතයක් විදිහට suicides කියන එක එතකොට වැඩි වෙනවා. හරි වැඩි වෙලා තියෙනවා. ඉතින් දැන් the proportionately yes the proportionately yeah suicides have gone up, and the agency which is working towards the maternal care is Family Health Bureau. So we are working closely with the Family Health Bureau to mitigate this this. And the other thing, we have already prepared the tools to identify early. එතකොට අපි දැනටමත් මේ පවුල් සෞඛ්‍ය ආරංචියත් එක්ක අහුවෙලා සමහර අපිට වේලාසනින්ම මේ මව්වරුන්ගේ සියදිවි හානි කර ගැනීමට එන සිතුවිලි එන අයව හඳුනාගෙන ඒකොල්ලන්ව අපේ මානසික සෞඛ්‍ය ප්‍රොෆෙෂනල් කෙනෙක් ළඟට ඒ වගේ එහෙම නැත්නම් සයිකියාට්‍රිස්ට් කෙනෙක් ළඟට යොමු කරන එක දැනටමත් දිගටම කරගෙන යනවා. අනිත් එක මම හිතන්නේ ඒක විතරක් නෙමෙයි. දැන් අර ඩොක්ටර් නීල් ෆර්නැන්ඩෝ කතා කරපු සයිකොලොජිකල් ඔටොප්සි කියන එක දැන් ඔය suicides maternal suicides වල දැනටමත් කරගෙන යනවා. And we have already piloted the suicide the psychological autopsy for all the suicides in Gampaha district, but due to the past all the failed conditions in the country, COVID and other and the petrol and all things, so we had to stop temporarily. Right?
Yeah.
Did I answer your question?
Yes, doctor.
Yes.
Thank you so much, Dr. Ratnayaka. And Dr.
Can I add to that?
Yes, I wanted to add. Please.
Can I add to what Rohan said?
Yes.
Now, pregnancy is a very vulnerable period of a woman's life from a mental health point of view. So we need to be on the watch out for that. And pregnancy and the postpartum period, that is after the delivery, that period is a vulnerable period. In fact, even in our law, it is recognized as a vulnerable period. So
Okay.
if a mother kills her own baby under the age of 1 year, that mother is not charged with the normal penal offense of murder. It is actually downgraded to a thing called infanticide.
Oh, right.
Now, why is that? Because the law itself recognizes that due to the pregnancy and the effects of lactation, a mother's mental state is not completely balanced. So as a result of that, an offense where she kills her own baby, of course, the baby has to be under the age of 12 months, then that is regarded as the responsibility of that offense is lesser than of that of a homicide. And the judge has the discretion. Now, that's the important thing. If it is a murder, judge has no discretion. If the accused is proven to be guilty, then the judge has to impose the death penalty, as we all know. But when it comes to infanticide, the judge has the discrepancy. Judge has the freedom to decide the penalty. And usually what happens is that, from a practical point of view, is that the judge is very lenient on this, in the sense based on medical evidence, generally lenient. Still it's an offense, but the punishment can be usually very lenient, or what we call a suspended sentence for a period. So that itself shows that this is a very vulnerable period. And to add to what Rohan said, actually there is a screening of all mothers after delivery at 1 month to identify postpartum depression. And that is something that has been done now over the years to detect, as Rohan said, depression early, and then necessary action to be taken. And recently, the psychological autopsy, of course, that is after the tragic event.
Okay.
Psychological investigation is done to find out what really went wrong in that particular mother.
Thank you, Dr. Neil. Very, very
Thank you, Dr.
informative.
Irfan. Yeah.
Dr. Ganesan, can I quickly ask you a follow-up on that?
Yes. I mean,
Doctor, now since I like to know whether mental health screening is done to a mother during pregnancy in the 9 months leading up. But that is the most important period where mental health issues can develop and can be detected and assessed.
yeah, I mean, the screening is a good attempt in a way to find the people at risk. But the problem is, I don't think the screening alone is going to solve the problem, because like you said, sometimes as other speakers also said, the idea of ending the life comes in 5 minutes, and then it's all done within the next 10-15 minutes. So in that sort of instance, just screening for alone is not going to be helpful, right?
Okay.
Because when somebody is screening, the person may be perfectly well, and then have a fight with somebody, or argument with somebody, or some either financial stress, they might commit suicide because of some issue around shame or whatever. So the important thing is close emotional support for those people. The screening can help us to identify depression, which is a cause for postpartum suicides. But as you said, unfortunately, that's not the only cause. So we attribute suicides, about 40% of suicides, to depression, depressive illness. So to some extent, the screening can pick that up, but not all mothers at risk. So having close supportive relationships, teaching husbands and others to show consideration, to care for the woman, and also during the pregnant time, teaching the mothers of the problems that they are going to face after having the baby.
Okay.
You know, it can be lost nights, it can be feeding issues, it can be financial issues. So preparation and ensuring adequate emotional support throughout. After having the baby, where are they going to be? Is it going to be in the mother's house or mother-in-law's house or separate house? You know, even small problems sometimes, we blow them up into huge controversies and cause a lot of emotional damage and harm, which can tragically end in, a death of a young mother. So it's important that the emotional needs are identified. There is proper planning. They are taught what are the problems that are going to come with the child. They are going to get less attention. There's going to be more trouble, more additional work. So all that has to be put into place.
Okay.
And that is very important.
Thank you, Dr. Ganesan, and all three doctors for your inputs, which was very, very interesting. And I'm sure a lot of knowledge has been gained by the listeners in. And let me move on to the next one. Now, we don't seem to have a national protocol to record deliberate self-harm hospital admissions, but there is a national protocol to record poisonings, including self-poisonings, through the National Poisons Information Center, which is the NPIC. Admissions for self-poisonings in children and youth are rising. NPIC figures suggest that the self-harm rate is potentially many times larger than the suicide rate. In 2006, again, data has told us that 4,500 people suicided, but 93,000 people were admitted to hospital for self-poisoning. The annual health stats of 2016, which was the last one I managed to retrieve, shows 78,000 admissions for poisonings, which is 370 per 100,000. While deaths by suicide have reduced since 1995, attempts at self-harm are rapidly increasing. Dr. Neil, one of the most important components of suicide prevention strategies should be to target people who attempt self-harm, as they are a high-risk group. What is being done in Sri Lanka to follow up on individuals who are discharged from emergency departments, medical wards, and mental health units so that the risk of future attempts can be minimized?
Yes, now the history is that until 1997, Suicidal Act was regarded as a criminal offense.
Yeah.
But it was after 1997 that criminality aspect has been removed, like in many other countries. So now the idea is that anyone who comes with a deliberate self-harm, once the medical side has been cleared, you need to refer that person for psychosocial evaluation. So that is that is the standard. But of course, as we know, these standards are not being carried out all the time. And so there is usually these people are generally lost after the initial medical treatment is over. Generally, I'm speaking in general terms, right?
Okay.
So that is something that probably we need to pay attention to. The other thing is that now you mentioned about the vast difference, 4,000 suicide and 93,000 suicidal attempts. But now again, we have to be careful. All these, most of these 90,000 are actually the intention is not to commit suicide.
Right.
As I said earlier, the intention can be very different. It can be killing oneself may not be the main intention.
Okay.
It may be to gain attention, maybe to manipulate other people, or maybe it's just a reaction to a stress, ongoing stress. So, but unfortunately, some of these people end up dying because of the method used or whatever the circumstances, right? And now, and also the mode, if you look at the mode of these attempts also has been changing, right? Now, earlier it was usually pesticide poisoning. But now it has changed. Now, most of these, what we call impulsive acts, are mainly due to overdoses of tablets.
Okay. Prescription drugs.
Of tablets, yes, prescribed or non-prescribed, over-the-counter drugs. So there is a tendency, and in a way that is a better tendency because pesticide poisoning, yes, there is more chance to save the life of the person. So there are certain changes happening, but I think we need to pay more attention because research has clearly shown that, the number of people who so-called attempt suicide is actually increasing, though the suicide rates have been falling.
Yes, and also, doctor, the data also shows that the people who finally complete suicide have attempted many times before. That is why it's necessary to target the attemptees. Don't you think so?
Yeah, that is correct, because the most important risk factor for suicide is a past attempt of suicidal behavior.
That's the point I'm trying to make. Yeah.
Yes.
So that is why. Them.
Yes, that is why we need to look after them. Yes.
Thank you. Thank you, Dr. Neil. Thank you very much. Dr. Ganesh, would you please help us with a Tamil response for this, please, in Tamil?
I mean, okay, I'll answer in English as
okay.
well.
Sure.
See,
Sorry.
I mean, no, what you asked was important, that deliberate self-harm is an important marker. But worldwide, the problem has been, as it is almost always a very impulsive act, they themselves feel very bad about it. And unfortunately, they don't keep appointments and they won't come for follow-up.
Okay.
Because that is something that, after deliberate self-harm, they won't come for follow-up because they don't want to talk about it. This is a stupid thing I did. I don't want to talk about it, and they don't like to come.
That's
and they
very
don't
interesting.
like anybody reaching out to them as well. So this has been one of the big challenges worldwide, because we can have elaborate plans and systems to try to call them back to a given appointment. No, they will not come, and that has been the universal issue. So the தற்கொலை முயற்சியை பற்றி கதைச்சது என்னன்னு சொன்னால், இந்த தற்கொலை முயற்சிக்கு என்ன பேர் செய்யணும், அதுல கொஞ்சம் பேர் தான் உண்மையான தற்கொலையில போய் முடியுது. சோ ஏன் இந்த தற்கொலை முயற்சி செய்யறாக்கள் தற்கொலையில முடிகிற இல்லை, ஏன் செய்யணும்னு கேட்டா பல காரணங்களுக்காக செய்யணும். அப்ப இந்த தற்கொலை முயற்சி செய்யறாக்களை நாங்கள் கவுன்சிலிங் செய்தோ என்னவோ செய்தால் அவங்க தற்கொலைகள், பிறகு வார தற்கொலைகளை தடுக்கலாமா என்ற ஒரு கேள்வி ஒன்று இருக்குது. அதுல என்ன பிரச்சனை என்று சொன்னால், தற்கொலை முயற்சி செய்யறாக்கள் அதை பற்றி கதைக்கவோ அதுக்கு உதவி எடுக்கவோ அவைக்கு விருப்பம், அவைக்கு அது வெக்கம். சோ அவைக்கு ஒரு அப்பாயின்மெண்ட் கொடுத்தாலோ அல்லது போன்ல கால் பண்ணி நாங்க கதைக்கோன் பண்ணாலோ அவை அதுக்கு விரும்புகிறோம் இல்லை. சோ இது ஒரு பெரிய பிரச்சனை. So yeah.
Dr. Ganesan, thank you. And also that important point you brought up about them not coming up for follow-up treatment due to, again, shame or probably, not interested in it. So another question, again, an interesting question. In 1984, Sumithrayo realized that over 35% of suicides were linked to alcohol use and abuse. Because Sumithrayo is involved a lot in data processing as well as research. That's how we get hold of these situations. So then it was decided to set up Malmadura as a rehab center, and that's still going on from 1984. There is no data presently on how serious the situation is now, but I came across the following studies which concern me. One study in a place called Gokarela found that 84% of all suicides had occurred after consuming alcohol. Another Sri Lanka study stated that psychological autopsy of 372 suicides in rural SL, Sri Lanka, found that problem drinking or alcohol dependency was common among male suicides in 61% of cases, while alcohol misuse in another family member contributed to 14% of female suicides. Another Sri Lankan study in 159 admissions of attempted suicide, 32% were visibly affected by alcohol. Dr. Ganesan, can you elaborate on the connection between alcohol and substance abuse with impulsive self-harming and suicide? How best can we reduce this connection?
Yes, I mean, that's a very strong connection between alcohol and suicide and deliberate self-harm. Even having a parent who is using alcohol increases the self-harm risk in children. That alone is a high risk factor for children because of the issues associated in the home front due to the fathers, very often the fathers drinking.
Yeah.
So this is a very strong connection that we know of. And so it as in association with the other risk factors like depression, domestic violence, other risk factors involved in this, it has a big amplifying effect on the suicides. So we know that alcohol is a central nervous system depressant. It causes depression. But when immediately after alcohol, there can be some euphoria, there can be some calmness, but alcohol is very well known to cause depression. There's no two words about it. That's very well known. But unfortunately, again, culturally, we are struggling to deal with this alcohol problem in our country. The alcohol industry is very powerful. Now, earlier, alcohol was sold in only particular places. Now, all the supermarkets have started selling alcohol. That is a huge problem. And also the way society sees alcohol and alcoholic behavior, how it is tolerated by society, is a huge problem. So somebody after alcohol is shouting or hitting other people. People are very, unfortunately, forgiving. And it's seen as a fashion, it's seen as a style, normalize it. And also the way the alcohol industry has prevented the real term prices going up. One of the very important things we know that helps in reducing alcohol consumption is availability. And price plays a very important role. So the higher the price, higher the cost of alcohol, less people will drink. But unfortunately, our prices have not kept up with inflation or anything. So alcohol in real terms has become cheap. And these are real concerns. You're absolutely right.
Yeah. Doctor, when you talk about accessibility, which is very important, we ask the question always to policymakers, why are wine stores open at 10 o'clock in the morning? Whom are they catering to?
Absolutely.
So,
absolutely.
I mean,
so these wine issuing wine licenses,
but before the opening hours, so that at least, you know, those people who are dependent on alcohol are not able to access it. Those are the morning drinkers, you know.
Yes. So the problem is about issuing licenses. It's a very politicized, lucrative method. So there are major issues in that whole area. And when something is politicized, the agencies who are supposed to monitor it also take a back step.
Absolutely.
And they are scared, reasonably. So we have a lot of system changes that has to be brought into this whole thing.
Okay.
And it's destroying lives. It's destroying lives.
Yes, doctor. So
can I also
yes,
add,
of course, Dr.
Yes, to what Dr. Ganeshan said now. So this is about this supply and demand. You see, the thing called supply and demand, increased supply and increased demand. And so we must always remember that there is an industry behind this. And the industry is actually promoting alcohol. From the supply side, that is to supply means manufacture and distribution of alcohol. And of course, the demand is the thing that is coming from the community side. So as Dr. Ganeshan pointed out very correctly, the price is a very important part. So consumption and price also are related to each other. So more you consume, more you have problems. So that is, and there was a very interesting study, 5 countries, all Asian countries and all Buddhist countries.
Okay.
And they looked at what are the people, what are the things that they are drinking actually. They compared the 5 countries, including Sri Lanka. All countries were Buddhist countries in Asia. And they looked at, if you take 100 people, what do they drink?
Okay.
That is about the alcohol, the content, the percentage of alcohol that is consumed. And it was very interesting. Sri Lanka came as the highest.
Okay.
So, for example, if you compare Burma and Burma or Myanmar, I think now it's called, if 100 people drink, 83% drink beer.
Okay.
Right? So beer consumption, which contains about 8% alcohol.
Okay.
Now, if you compare Sri Lanka, if 100 people drink, 85% drink spirits. That is arak and the illicit, the kasipu, which has about 40% alcohol.
Okay.
So that itself shows that our people are consuming more alcohol in their drinks, right? And that also affects, as Dr. Ganeshan said, affects the well-being of the person.
Yes.
So these are very interesting things.
Yes.
So alcohol and suicide, alcohol and depression, all these are actually interrelated things. Yes. Yes.
Thank you. Thank you, Dr. Neil and Dr. Ganeshan, for those very important insights, which I hope all of us.
Can I add a small sentence?
Of course, of
Yes,
course.
I mean, Sri Lanka is a Buddhist country, but there are significant other minorities also, like Christians, Hindus, and Muslims. Except for the Muslim community, even there the alcohol consumption is going up now. It's a big problem in the Christian and the Hindu communities as well.
Okay. That's interesting because those are trends that we need to study. So, okay, I'll just move on to the next question. The 2021 suicide stats from the police show the following trends. Actually, male-female ratio is now 4:1. 75% are married, people who take their lives. 50% are educated between grade 1 and 8 only, 50%. 30% have O-level, sorry, up to the O-levels rather. 40% are aged between 15 and 35. Interestingly, 20% are over 66 years. 65% are employed. 35% unemployed. 66% died by strangling. Dr. Neil, your comments on these trends and how important is it to study suicide trends when formulating prevention strategies?
Yeah, there no doubt it's very important to study. Now you mentioned about the police. Now, when we talk of police, you have to be careful also. Now, we know that police are the most reliable. Statistics are the most reliable when it comes to the number of suicides. Because as you know, suicide is regarded as an unnatural death.
Okay.
So for in Sri Lankan law, all unnatural deaths must have a inquest after the death. And this inquest is carried out by the police. In the sense that organizing the inquest is done by the police. So the police will have a lot of statistics in relation to that. So what you mentioned is all true. But if you look at, there is another column, the causes of suicide.
Yes.
That is the place where you have to be careful. Because what they mention under causes of suicide is what is mentioned at the inquest.
By the relatives. By the survivors.
By the survivors. By the relatives.
Right,
now, you understand the mental state of the survivor. Now, suicide is a sudden, unexpected death. Causing great trauma to the survivors, the family members. So they are in a very traumatic situation, and the inquest is held very soon after the death, and the body is not released until the inquest is over, and the relatives have to find some reason for the suicide. So usually what happens is that it is the immediate preceding stress that is highlighted as the cause. And that is what is stated in the police statistics, which is actually not true. I'll give a good example. A study was done by Dr. Anil Abesinghe, psychiatrist at Peradeniya. They studied suicides reported in the Kandy district over a period of 3 months in the papers. These suicides were reported in the papers. And they studied and they found out that actually 90% in that study, 90% of the suicides after a psychological autopsy was related to undetected depression and alcohol problem. But that is not what it was reported in the press. They were giving very trivial things, right? So you need to actually go into deeper aspects to actually find out. So police statistics are good with regard to the numbers, but I think you have to be careful
I
when you
know.
are interpreting the causes.
In fact,
Yeah.
doctor, under causes, they give alcohol and drugs as only 4%.
Yeah, can I come in? Yeah,
Of course.
yeah. The one reason is also, one of the reasons is that the relations are revealing the things to the law enforcement officers. So this is not the true picture. That is one thing. When a medical person or someone away from the law enforcement agencies are involved, I think we can get a good picture. And we will be doing this also. As I told you earlier, the country's situation was not
Okay.
conducive to continue that. But as now it's high
Yes.
time that we will execute this
That's
process.
good news. Dr. Neil was talking about the mental health of survivors, and I have a question on that. The mental health of survivors and bereaved relatives is very important to address. Bereavement or grief due to suicide is experienced very differently from mourning of a loss by natural causes. Stigma associated with suicide plays a big role, and family and friends find it very difficult to reach out and unsure what words of comfort should be offered. As a result, a kind of wall of silence is built by friends, family, and the community, who may discuss the suicide in hushed tones amongst themselves. Survivors may go through feelings of guilt or blame that they were the cause or did not do the needful to prevent the suicide. They may choose to deal with it by denial or even avoiding discussing it. If the grieving process is not allowed to proceed, some survivors may place themselves at risk for suicide. It is very important that the bereaved seek assistance, but the stigma often prevents them from seeking help. Dr. Ganeshan, your views on this?
Yeah, this is a very important topic. I mean, each suicide affects at least 17 people quite seriously. It's not only the family, even friends, very close ones, because they also feel a sense of betrayal. You know, he didn't share it with me, she didn't tell me, I could have helped, you know, I was a friend, I was close to her, but how did I miss it? So there's a lot of guilt,
Yes.
anger, and all the things associated with grief are there in suicide deaths, and it's actually more, as you said. And it's very important that the family gets the support. You know, I mean, one of the things we say is suicide is not preventable, very difficult to prevent it. When somebody really wants to die, it's very difficult to stop it at that point. So, and also to help them to go, and we try to fix it into their, you know, lack of understanding of there are close people that I can talk to, there are family members who will be helping me, and the person failed to see those things. So we make sure that the blame is not on the survivors, right?
Okay.
And it's cruel even to
Okay.
think of that. So we have to be very careful how we talk,
Yes.
and also, like you said, you know, avoiding them, not going to their houses, avoiding talking about it.
Yeah.
It's not fair. We should not do that.
Yes.
We should be there for them to talk, and we should then treat them as normally as possible.
Yeah.
And also be there to support, and that's
Yes.
very, very important.
I also know,
Yes.
doctor, when there is a suicide in the family, they find it very difficult to give their daughter in marriage because people feel that there's mental illness in the family.
So that again, we have to be very careful to tell people that this is a, you know, a problem solving approach.
Yes.
I mean, this is not a serious mental illness.
Yes.
We need to. Yes.
Doctor, can
Absolutely.
you give us a quick take on this, on your answer in Tamil, please?
தற்கொலை ஆக்கள் செய்யக்குள்ள அவைண்ட குடும்பத்தாக்களும் மிகவும் அதிகமாக பாதிக்கப்படுவினம். உதாரணமாக ஒவ்வொரு தற்கொலையும் கிட்டத்தட்ட 17-18 பேரை மிகவும் ஆழமாக பாதிக்குது. இது குடும்பத்தை மட்டுமல்ல, நண்பர்கள் நண்பிகளையும் கூட இது பாதிக்குது. ஏனென்றால் நான் அவையோட இருந்த, நான் அவை இந்த ஃப்ரெண்ட், அவ ஏன் எனக்கு சொல்ல இல்லை, அவள் ஏதாவது நடந்திருக்கு, நான் அதை கவனிக்காம விட்டுட்டேனோ என்றெல்லாம் அவைக்கு மனதுக்குள்ள எத்தனையோ குற்ற உணர்வுகள் எழுந்து கொண்டிருக்கும். அதே மாதிரி தான் குடும்பத்தவர்களுக்கும் அவர்களுக்கும் மனதிலே எவ்வளவோ விதமான குற்ற உணர்வுகள் ஏற்பட்டுருக்கும். அப்ப அதைக்கு நாங்கள் அதுல இருந்து மீண்டு வாழ்றதுக்கு உதவி செய்யறது எங்கள் எல்லாருடையும் கடமை. அது அந்த குற்ற உணர்வு வளராத விதத்தில இல்ல நீங்கள் ஒண்ணு செய்திருக்க இயலாது, தற்கொலை செய்ய சாகுன்னு முடிவெடுத்து அதை நிப்பாட்டுறது வேலை கஷ்டம், சொல்லாட்டி நாங்கள் எப்படி அதை கண்டுபிடிக்கிறது, நீங்கள் அதை நிப்பாட்டி இருக்க இயலாது போன்ற ஆறுதல் வார்த்தைகளை சொல்லி அந்த குற்ற உணர்வு வர்றதுல இருந்து தடுக்கிறதோட நாங்கள் அவையோட சாதாரணமா இந்த வீடுகளுக்கு போய் அவையோட கதைச்சு அவையோட பழகுறது, அந்த அவையையும் சமூகத்துல உள்வாங்கிறது, எங்களோட உறவுகளை பழுதாக்காம உள்வாங்கிறது வந்து அவைக்கு பெரிய ஒரு ஆறுதலை கொடுக்கும். ஆகவே இதை நாங்கள் ஞாபகத்துல வச்சிருக்கிறது மிக மிக முக்கியம்.
Okay.
Thank you.
Thank you, Dr. Ganesan. Thank you very much. Can you say something in Sinhalese, Dr. Neil, please?
Yeah, this will be a very important thing. So I will summarize some points that were raised in Sinhala.
Thank you.
Then මේ සියදිවි නසා ගැනීමේ වැළැක්වීමේ ක්‍රියාවලිය එක වැදගත් කොටසක් තමයි මේ සියදිවි නහගත් අයගේ ඥාතීන්ගේ මානසිකත්වය පිළිබඳවත් සොයා බැලීම. ඔබ කවුරුත් දන්නවා සියදිවි නහා ගැනීමක් කියලා කියන්නේ බලාපොරොත්තු නොවූ හදිසි මරණයක් බොහෝ විට. එතකොට ඒක නිසා ඒ ඥාතීන්ට මිත්‍රයින්ට ඒ වියෝව හුඟක් තදින් දැනෙනවා. ඉතින් ඊට අමතරව තව දේවල් ටිකක් බලපානවා. ඥාතීන් සහ මිත්‍රයින්ට වරද පටවීමේ හැකියාවකුත් තියෙන්න පුළුවන්. මේක හුඟක් වෙලාවට ඥාතීන් අතර සිද්ධ වෙන දෙයක්. උදාහරණයක් හැටියට ස්වාමී පුරුෂයා සියදිවි නහගත්තොත් හරි හෝ වැරදි හෝ බිරිඳට තමයි හුඟක් වෙලාවට එහි වගකීම වැටෙන්නේ. විශේෂයෙන්ම මේ ස්වාමියාගේ ඥාති පාර්ශ්වය. ඉතින් බිරිඳට හුඟක් වෙලාවට දොස් පැවරීම එහෙම කරනවා. දැන් මේවා නිසා අර ඇතිවෙච්ච පීඩාවට අමතරව සමාජය විසින් එල්ල කරන පීඩාවනොත් මේ අයට විඳ ගන්න වෙනවා. ඊට එහා ගිය තව දෙයක් තියෙනවා. මේක හරි වැදගත්. මේක තාම මෙතෙක් කතා වුණේ නැහැ. මේ සියදිවි නසා ගැනීම පිළිබඳ වාර්තා කරන විශේෂයෙන් මාධ්‍යවල වාර්තා කරනදී බොහෝ විට අට කනගාටුයි කියන්නේ මාධ්‍ය වලින් වගකීමෙන් තොරව මේ සියදිවි නසා ගැනීම වාර්තා කරන නිසා විශේෂයෙන් ඒ මරණු විදිය මරණු ආකාරය ඒ විතරක් නෙමෙයි පින්තූරු පවා පෙන්නලා ඒ විදිහට වාර්තා කිරීම තුළ ඒ ඥාතීන්ට අර තමන්ට ඇතිවෙච්ච වියෝදුක තවත් දෙගුණ තෙගුණ වෙලා තමයි එන්නේ. ඒ නිසාම සමාජය විසින් ඔවුන්ට සහයෝගය ලබා දිය යුතු අවස්ථාවේදී ඒක ලබා දීමට දීමේ වැළකී ඉන්නත් පුළුවන්. ඉතින් ඒ නිසා ඉතාමත් වැදගත් වෙනවා මෙවැනි පිරිසත් අපේ අත දෑත දිගන්න සියදිවි නහා ගන්න උත්සාහ ගන්න අයට විතරක් නෙමෙයි, සිතුවිලි තියන අයට විතරක් නෙමෙයි, සියදිවි නහාගත් අයගේ ඥාති මිත්‍රයින්ටත් අපේ දෑත් දිගු කිරීම සහ ඔවුන්ට අපේ සහයෝගය ලබා දීම ඉතාමත් වැදගත් කාර්යයක් වෙනවා. මම හිතන්නේ මේ සියදිවි නසා ගැනීම වැළැක්වීමේ දිනේ එක වැදගත් අරමුණක් තමයි ඒ අංශයටත් අවධානය යොමු කිරීම.
Thank you very much, Dr. Neil. Thank you so much, Dr. Ganesan. That was great. Okay, it seems that more women than men say they have considered suicide, though more men actually take their own lives. Women talk about how they are feeling far more often than men. Women are also more likely than men to have stronger social networks and to seek counsel or medical support. Our 221 data shows the male-female ratio of deaths by suicide is 4:1 now in Sri Lanka. Dr. Neil, could the reason for more men to self-harm be connected to the gender stereotypes embedded into our culture and reinforced by role models and media? Would you like to comment on that?
Yeah, that may play a part. And also, as you said, I think you partly gave the answer also. Women have, as you said, more social
Networks.
Yes, network connections. And also, they they come to the medical attention more than the men.
Yes.
So that is why illnesses in women are detected earlier than illnesses in men
Yes.
because of the medical contact. And sometimes these things are picked up in the medical field as well, the emotional distress and things like that. Whereas in the males, I think they also they find it difficult to bring out their emotions. That is one aspect.
Okay.
Emotional expression is reduced compared to females,
Okay.
as well as, of course, the alcohol also plays
Okay.
a role there. They tend to use more alcohol to sort of bury or hide the
Okay. That's interesting.
distress
Yes.
and the emotional aspect. So these are all interesting areas.
Yes.
But as a fact, what you said is quite true.
Okay. Thank you. Thank you very much. Dr. Ganesan, a quick roundup on that in Tamil would be nice.
ஏன் ஆண்கள் கூட தற்கொலை செய்யணும் என்ற ஒரு கேள்வி ஒன்று இருக்குது. பல காரணங்கள் இருக்கு. ஆண்கள் உதவி கேட்கறது குறைவு, உதவி பெற்றுக் கொள்றது குறைவு, இந்த சமூக தொடர்புகளும் இதனை பற்றி கதைக்கக்கூடிய மாதிரி நட்புகள், தங்களுக்கு இருக்கிற பிரச்சனை கதைக்கக்கூடிய அளவுக்கு நட்புகள் இருக்கிறது இல்லை. மற்றது இந்த மது பாவனையும் ஒரு அவை இந்த தற்கொலை வீதங்கள் அதிகமா இருக்கிறதுக்கு ஒரு முக்கிய காரணமா இருக்குது. டன்.
Okay, thank you so much. So then the media also needs to reduce or eliminate altogether the sensationalism associated with suicide reporting, as all of you know. They must avoid giving graphic details of the method used and avoid using words like commit, which makes it sound like a crime. Providing details of the mechanism and procedure used to carry out a suicide may lead to the imitation of suicidal behavior by other people at risk. They can avoid simplistic explanations for suicide. They must encourage public understanding of the complexity of suicide. Avoid labeling places as suicide hotspots. Above all, if a suicide helpline is given at the end of the report, it will help other vulnerable people with suicidal thoughts to make contact and prevent an impending suicide. Dr. Ganesan, your views on this?
I mean, yes, the media's role is very, very important. And in Sri Lanka, media has been pretty good until fairly recently. There was a guideline. Again, I think under one of the previous presidents, a committee was set up to give media recommendations, and to some extent they were implemented.
Okay.
But unfortunately, it's kind of a decaying a little bit now. So it's good time that we visited it again and came up with some new media guidelines. And also, unfortunately, no such guideline seems to exist in India. So lots of movies and Indian media, which is a lot of people do watch here and listen and read. And there it is highlighted. And so that is a problem that I don't know how we can overcome. So media playing a very responsible role is very important.
Okay, so the last question. Sorry, yes, of course.
Can I also add in Sinhala?
Of course, please.
මේ මාධ්‍ය සහ සියදිවි නසා ගැනීම වාර්තාකරණය පිළිබඳ ඒක ඉතා හරි වැදගත්. දැන් ඔබ දන්නවා අපේ රටේ සියදිවි නසා ගැනීම වැළැක්වීමේ ප්‍රතිපත්තියක් තියෙන රටවල් 14න් එකක් අපේ රට. අනිත් එක මේ ප්‍රතිපත්තිය එළි දකින්නේ 2000 වසර හෝ ඊට වසරකට ඉස්සෙල්ලා වගේ. එතකොට ඒකේ එක නිර්දේශ 6ක් තිබුණා. ඒ නිර්දේශ 6න් එක නිර්දේශයක් තමයි මේ වගකීමෙන් යුතු මාධ්‍ය වාර්තාකරණය පිළිබඳ සියදිවි නසා ගැනීම. එතකොට ඒකේ ගයිඩ්ලයින්ස් බේසික් ගයිඩ්ලයින්ස් ටිකක් දුන්නා. එකක් තමයි අර අතිශෝක්තියෙන් සියදිවි නසා ගැනීම වාර්තා නොකරන්න. අර කියපු විදිහට සියදිවි නහගත් ආකාරය, පාවිච්චි කරපු ද්‍රව්‍ය, ඒ ක්‍රමවේදය මේවා ගැන වාර්තා නොකරන්න. වාර්තා කරනවා නම් ජීවිතයේ වැදගත්කම නැත්නම් ජීවිතයේ තියෙන වටිනාකම ඉස්මතු වෙන ආකාරයට ඒක වාර්තා කරන්න සහ ගැඹුරින් අධ්‍යයනය කරලා වාර්තා කරන්න. ඉතින් මේ තමයි මූලික වශයෙන් ඒ ප්‍රතිපත්තියේ තිබුණු නිර්දේශ. ඉතින් ඒවා හුඟක් වෙලාවට මේක ඒ විදිහටම කෙරෙන්නේ නැහැ. දැන් මාධ්‍ය කිව්වම මෙතනදී අපි මතක තියාගන්න ඕන මාධ්‍යයන් තුනක් තියෙනවා. මුද්‍රිත මාධ්‍ය, විද්‍යුත් මාධ්‍ය සහ සමාජ මාධ්‍ය, social media. ඉතින් මේ හැම එකකම දැන් මේවායේ සමහර ඒවල් මේ සියදිවි නහගන්න ආකාරයේම වීඩියෝ කරලා එහෙම පෙන්වන අවස්ථාවක් තියෙනවා. ඉතින් මේවා ඇත්තම හුඟක් වෙලාවට සියදිවි නසා ගැනීම ප්‍රොමෝට් කරන්න උදව් වෙන බව බොහොම පැහැදිලිව පෙන්වලා තියෙනවා. ඉතින් ඒ නිසා මේ මාධ්‍ය වාර්තාකරණය පිළිබඳව මම හිතන්නේ මම පෞද්ගලිකව මේ කටයුත්තට දායක වෙලා තියෙනවා 2000 වසරේ ඉඳලා වගේ. ඉතින් නම් අවුරුදු 22ක් ගිහිල්ලත් මම නම් තාම සතුටු වෙන්නේ නැහැ අපේ මාධ්‍ය මේ වගකීම හරියාකාරව කරන එකක් සම්බන්ධව. ඉතින් ගයිඩ්ලයින්ස් හදලා තියෙනවා. මොන තරම් ගයිඩ්ලයින්ස් හදලා තියෙනවා. නමුත් ඒවා ඉතින් පිළිපැදින විදිය තමයි ප්‍රශ්නේ තියෙන්නේ. ඉතින් මම හිතන්නේ ඒක අපි නැවත කතා කළ යුතු කාරණයක් වෙනවා මේ වගේ දවස්වල.
Okay. Thank you very much, Dr. Neil and Dr. Ganesan. That important question. So one last question, which I hope all three doctors can contribute, is about interventions. When Sri Lanka had the highest suicide in the world in 1995, a presidential task force for prevention was formed, which led to the implementation of several preventive measures. The most significant of these being the banning of certain class 1 pesticides. Other notable measures include the decriminalization of self-harm attempts, measures to ensure responsible media reporting, introduction of life skills in school curricula, and teaching undergraduate and postgraduate medical students the assessment of persons who had engaged in self-harm and aftercare. Dr. Neil, how successful have all these been? Were all of them implemented, and should policymakers and stakeholders sit together again and plan new strategies?
Yeah, I mean, any policy has to be updated with time. Now, when this policy was brought forward, the mode of suicide, the predominant mode of suicide was pesticide poison.
Yeah.
So obviously, out of the 6 recommendations, 3 were related to pesticide poison.
Okay.
Which is something that we can understand.
Okay.
Now we know that it is not the pesticide poisoning.
Yeah.
Now the highest suicide method is hanging. So the methods have changed, and also certain other things have changed over the period of time. So as you said, suicide policies also need to be looked at from time to time, and it has to be updated. Now, what you said, all those things were started. Now, for example, teaching life skills in schools, that was started, right? All 6, from 6 to 9, year 6, 7, 8, 9 grades. It was included in the curriculum. Initially, as life skills, that was the subject. Singaling kiwe Jeevana Nipunata, right? That was but that was a subject that was not tested at an exam.
Okay.
Right? So as a result of that, you know our schools,
Okay.
they want results. So what really happened was that actually there was a study done by a postgraduate on the effectiveness of this life skills program. How effective is life skills program, and it was very clear that it is not effective. Though it is there in the curriculum, it is not adhered to because it is not a examination tested subject.
Okay.
So most of the time that is allocated to that has been given to math, science, and various other things.
Okay.
Which are more important from a principal's point of view than life skills.
Okay.
The other thing is, then what happened is that I'm just telling what evolved. Then life skills was, though it was a separate subject, now it is not a separate subject. Now it is called Puravasi Adhyapana. එහෙම කියලා life skill එකත් ඒකට ඇතුල් කරලා වෙන කතාවකුත් එක්ක තමයි යන්නේ. So that is one thing. Other thing is the teachers who are allocated to that life skills. That I am referring to that study done by one of the postgraduate trainees. Indicates very clearly that the most inefficient teachers, if I use that word, are the ones that have been allocated to this subject, right? So
that's very sad.
It's very sad. It's very sad. So though it is there in the book, what actually comes out of it is not very good. So I think we need to revisit that. So life skills education also, it should not be only in schools. It should be also in the universities as well. And
also for parents and teachers too.
Tertiary education institutions, yes. They need life skills education. Yes.
So thank you, Dr. Neil. And Dr. Ganesan, any inputs from you on this?
Yeah, I mean, blaming the school system alone is not good enough. The parents also have to take some responsibility. Unfortunately, memorizing and putting it out in exams and seeking jobs based on that and prestige is putting a lot of pressure on children, and they grow up with less and less life skills. So the school has to play a role, and the parents also has to play a role. I mean, one of the big problems we have is poor problem solving skills. When we face a problem, how do we solve it? Unfortunately, children are not allowed to do that. You wait, we will tell you what to do. The parents always kind of direct the children, and when they are in a situation where there are no parents to direct, or there are issues that they can't discuss with the parents, then the children don't know what to do. So these are very important areas, how we bring up our children, how we educate our children. It's very, very important.
Okay, thanks, Dr. Ganesan. And Dr. Ratnayaka, we'd like to hear something from you.
Yes. I think the education ministry is changing some of the, as Dr. Neil Fernando said, yes, it has happened sometimes as punishment. So the teachers were allocated to this subject, but now it is being changed. And the Directorate of Mental Health has an expert committee on suicide prevention. So this is a functioning body, and we think that an expert committee or some other the hierarchical body should come under Prime Minister or President, right? Because this is there's a highly prioritized public health area also, and most of the factors lie outside the health system, but it was not the government policy that time. So and we have come up with the strategic plan and action plan, which are being piloted nowadays, and we will be able to the disseminate in maybe within a month's time.
Okay, that's good news, Dr. Ratnayaka. Very good news. So, but dear doctors, I do hope that you enjoyed answering my questions. And now it's time for you to answer questions from the attendees. So can I start off? So I think the first one is directed to Dr. Ganeshan. Does NIMH provide any support to those who are struggling to get a family member who is mentally ill, but refusing to accept it, to seek medical support? Is there any other form of support available to the family to get the mentally ill person to seek medical support?
Yeah, good question, the current issue. But unfortunately, there are some problems with the current Mental Health Act for us to go ahead with that. That is one issue. And in spite of that, we did try doing that for some time, about 4 or 5 years ago. But unfortunately, the government system of, allocating an ambulance and what the ambulance goes for are a problem. So unfortunately, that service is not provided by NIMH. It's up to the families to find some private people or get the help from police to bring them to hospital. And it's a highly unsatisfactory situation. So first we
Okay.
have to amend the Mental Health Act, which is old and not working,
Okay.
which should happen soon. And also we need to develop that service. Yes.
Yeah,
Okay.
Dr. Ganeshan, it's been amended now. We met the minister, Mr. Vijayadasa Rajapaksa also recently with the College of the Psychiatrists. Yes.
Thank you. Thank you. This question has been directed to Dr. Ratnayaka. What measures has the Ministry of Health taken to educate medical staff, nurses, minor staff, etc., on how to support and treat suicide attempt survivors? Is there work happening to sensitize them around treating attempt survivors with respect while maintaining their dignity?
Yes. To a certain extent, it's happening, but I don't say that to a satisfactory level.
Yeah.
That we have to take the responsibility for that also. And as I said, so all these are in the suicide strategy in that package, right? So we to tell you we have initiated the first program in Kilinochchi yesterday and day before.
Okay.
Yeah, dignity. Yes, dignity is a problem all over the country.
Again, this refers to the kind of self-esteem that a patient is reduced to, when he's maybe scolded in the hospital, or, people feel that, it's just something done for attention seeking, and, they kind of minimize the issue. Anyway, thanks, Dr. Ratnayaka. This next question is to Dr. Neil.
Can I
Yes,
add to that?
of course.
I mean, to some extent, that the problem, part of the responsibility has to be taken by our patients as well.
Okay.
Whenever there is a poor quality service, whenever somebody is rude, they have a responsibility and a duty to complain about it. So hospitals, health services run out of people's money, and they have all the right to ensure that good quality is there. So in some ways, anonymously or somewhere, it's not for suicide or any other thing. People should bring it up.
Okay, doctor. Thank you very much. This question is to Dr. Neil Fernando. We know that certain high-risk occupations, like being a medical doctor, nurse, etc., can increase the risk of suicide due to easy access to means. We saw this happen during the first lockdown when COVID-19 started. Are there measures taken by medical administration to ensure that there are safeguards in place and that there is mental health support offered for health professionals?
Yeah, so I think there is no specific measures that I know of. Probably Dr. Rohan Ratnaik might be a better person to answer this.
Okay.
I'm very sure about the current trends that is happening in the health ministry. But the point is very well taken. That is very important. The health workers are also at a risk.
Yeah.
And studies have shown that certain health workers are more at risk than others. So, treating the health workers has been a problem actually, not only in our country, but in other countries as well. The sick doctor. Doctor means it's not only the doctors, the other includes the other
Frontline workers.
Frontline workers. So whether there is a specific program to address that issue, as far as I know, there is no such program, but probably I stand to be corrected. Probably Rohan might be able to give a definitive answer.
Yes, yes. We conducted the one program during COVID time, but I think this, we have to continue that even after that, even after the epidemic or any other the emergencies. So this has to be a continuous and sustainable process. So,
Okay.
yeah.
Thank you very much. I think this next question is about my question about maternal suicides. It says the Edinburgh scale that is administered as a screening for pregnant women may not be effective as questionnaires rarely bring out complexities in a person's life during pregnancy. Can midwives and others be trained to conduct a more comprehensive risk assessment?
Can I answer that? Because
Of course.
I
Yes.
was involved in this validation of this Edinburgh scale.
Okay, okay.
The original research, I was also involved. Actually, it's a screening test. So please remember that screening tests are screen tests, right?
Okay.
So it depends on the sensitivity of the test to detect depression, and that is why we do it at the end of 1 month to catch more and more people, because we know that depression generally starts around the 2nd week.
Okay.
So that is why 1 month is after another 2 weeks to catch more people. But yes, it's a self-administered questionnaire. Now, like all self-administered questionnaire, if you are not honest, then you will not detect, right? But at least this is detecting some. That is the important thing. We may not detect everyone who is depressed, or you might get depressed.
Okay.
But at least it is detecting people, and the system is there, so that doctors get a chance to actually look at them. So I think it is there. Now they are thinking of even administering it before the pup. Now this is after the delivery, during the pregnancy, whether it can be depression can be detected, and even mental ill health can be detected. So there is a possibility that women will be screened even antenatally on mental health issues.
That's great news.
Yeah, yes.
Yeah, thank you, Dr. Neil.
අනිත් එක තමයි මම සිංහලෙක් එඩින්බර් ස්කේල් එකේ දැන් සමහර ඩොක්ටර් නීල් ෆර්නන්ඩ් කිව්වාගේ ඔනස්ට් නැත්තනුත් එහෙමයි. සමහර වෙලාවට මේ අර ක්ලිනික් සෙටින් එකේ දැන් ඒවල් එන අම්මලාට සමහර වෙලාවට මේක ගැන ලොකු සිග්නිෆිකන්ස් එකක් ඒගොල්ලන් දෙන්නේ සමහර වෙලාවට. එහෙම ඒවත් තියෙනවා. එතකොට දැන් මොකෙන් එන රිසල්ට් එක එහාට මෙහාට වෙන්න පුළුවන්. ස්කේල් එකේ ප්‍රශ්නයක් නෙමෙයි අත්තටම. අනිත් එක ස්කේල් එකේ තියෙනවා සුයිසයිඩ්ලිටි එක ගැන අහලා තියෙනවා. එතකොට ඒ වගේ කම්පොනන්ට්ස් වලට ඒගොල්ලන් ඒකට හරි දාලා තියෙනවා නම් ඉක්කලා තියෙනවා නම් ඒවා සමහරවිට මේ අවදානම් සාධක විදිහට ගන්න ඕන තරම් හැකියාවක් තියෙනවා.
Okay, බොහොම ස්තුතියි.
ඒකටම පොඩ්ඩක් එකතු කරොත් ඇත්තම මේ ස්කේල් එක ගෙදරදි කරා නම් වඩා හොඳයි. මේ ස්ක්‍රීනින් ටෙස්ට් එක ගෙදරදි කරා නම් වඩා හොඳයි කියලා හිතෙන්නේ. එතකොට මවට නිදහසේ ඒකට උත්තර දෙන්න පුළුවන් වෙනවා. බිසි ක්ලිනික් එක මේ පැත්තකින් වාඩි වෙලා අනිත් අය ඉස්සරහා මේක කරන එක ටිකක් අපහසුයි. ඉතින් ඇත්තෙන්ම මට හිතෙනවා වඩාත් ප්‍රතිඵලදායකයි මිඩ්වයිෆ් ගෙදරට ගිහිල්ලා මාසෙකට පස්සේ ඒ විසිට් එකක් කරලා ගෙදරදි මේක කරන්න පුළුවන් වුණොත් මට හිතෙනවා මීටත් වඩා ප්‍රයෝජනවත් වෙයි කියලා. ඒක මගේ පෞද්ගලික අදහස. බට් ඉතින් හුඟක් වෙලාවට වෙන්නේ අර මාසෙකට පස්සේ බබාව ගේනවනේ බර කිරාට. එතකොට තමයි හුඟක් වෙලාවට මේකත් ඇඩ්මිනිස්ටර් වෙන්නේ. ඉතින් අර අපි දන්නවනේ අපේ ක්ලිනික් සෙටප් එකේ මව්වරුන් ඒ වෙලාවෙත් ඒගොල්ලොත් ඉන්නේ පුළුවන් ඉක්මනට ගෙදර යන්න. ඉතින් අර මේවා ගැන මේ හරියටම බලලා උත්තර දෙන්නෙත් නැතුව ඇති. ඉතින් එහෙම තමයි. ඉතින් ඒ ඕනම ස්ක්‍රීනින් ටෙස්ට් එක තියෙන ගැටලු තියෙනවා මෙතනත්. හැබැයි අපි කියන්න ඕන people are identified by this screening test and referred to the mental health professions, and that is something that we need to appreciate.
Thanks, Dr. Neil. This one, doctors, we have just about 5 minutes to go to light the candle. So try to run through this fast. I don't want to disappoint the people who ask the questions. Suicide is often linked quite strongly with depressive illness. However, I am curious to know why we don't talk enough about other mental illnesses like bipolar disorder, schizophrenia, and perhaps certain personality disorders and their association with suicide and self-harm. Dr. Ganesan?
Yes, I mean, there is an association, and that's the right question. But if you take the numbers, I mean, the depression is far, far more common than schizophrenia or bipolar or personality disorder. So therefore, and the suicidal risk is also slightly higher when people are having depression. But yes, it does. It is a problem for other people also, and we need to talk about that as well. You're right.
That's great. Quick question to Dr. Neil from somebody. What would be the current Sri Lankan socio-economic effect, the emotional health of individual who finds it difficult to fulfill daily needs? Isn't poverty play, risk of suicide thought or involving? It's a bit distorted, but
Very, very short answer. Poverty and mental health is related to, they are connected. Mental illnesses and poverty are related. There is a what we call a vicious cycle, Vishama Chakra. මානසික රෝගයක් හැදුනම දරිද්‍රතාවයේ වැඩි වෙනවා. දරිද්‍රතාවයේ වැඩි වුණාම මානසික රෝග තත්ත්ව උත්සන්න වෙනවා. ඉතින් මේ දෙක අතර බොහොම කිට්ටු සම්බන්ධයක් තියෙනවා. ඉතින් ඒ නිසා දැනට අපේ රටේ මිනිස්සු මුණ දෙන මේ ආදායම අඩුවීම, දරිද්‍රතාවය මේවා කෙලින්ම ඔවුන්ගේ මානසික සෞඛ්‍යයට අනිවාර්යයෙන්ම බලපාන.
Okay, thanks. Is Dr. Ganeshan, are you there? Dr. Ganeshan?
Yeah, I'm here. Yes.
A quick one for you, 1 minute.
Yes.
Dr. Ganeshan, can you please expand on being sensitive to shame?
Yes, so that's the question that takes more time, but it's okay. So basically, accepting me as I am, right? So as a human being, I have abilities that I'm good at, and there are lots of things that I'm not good at. When I make mistakes, and that's part of being human. So accepting me who as I am, and also valuing me who as I am, not necessarily based on other people's assessment. I know who I am, full stop. But others think about me, I'm not that much bothered. I do what I think right. If I make mistakes, I correct them, and I'm not ashamed of that.
Okay.
And bringing up children to kind of in that way, to what we call internal locus of control, knowing what you are doing is right or wrong, and working on it. Yeah.
Thanks, doctors. I do hope you all enjoyed being here with us today. And I think your answers were really fantastic and would have given all the people a lot of knowledge and awareness about suicide and other things too. So can I place on record our very grateful thanks to 3 of you for gracing this occasion and participating so willingly with us, so warmly and so humbly with us, I would say, which is really fantastic. So thank you again. And we are just, can we light this candle now? People who are able to. These are our contact numbers for anybody who needs help or who knows somebody who needs help can contact Sumithrayo. And also anybody who needs help with addiction, anyone is struggling with addiction issues, can contact Mal Madura. These are the numbers for Mal Madura. This is my candle. So thank you very much. It's just 8 o'clock and we are closing. Thank you very much for everyone who found the time to Zoom in. And thank you to the panelists for their time and the expertise. Good night, everybody.
Good night.
Night.